All right, good afternoon, everybody. This is Lloyd with AVS Medical. Thank you for joining me today. Before I get started, if you dialed into the webinar earlier, you know that we had some audio problems and as a result had to use a backup conferencing service. And there was just a lot of background noise on the phone, so I am actually going to go ahead and re-record the webinar. I know your time is very valuable. I want to make sure that we give you as much information as we can in a clear and concise way. So I'm going to go ahead and re-record this. And before I begin, just let me go through our standard disclaimer here. We're working hard to bring you timely and accurate information, but ultimately it's up to each practice and each provider to ensure that they fully understand the meaningful use rules, how their EMR software works within those rules, how the data is captured and reported on, and how they need to add the information so that it counts towards meaningful use. Today's presentation is really going to be focused on stage 2. I know that some of you may still be in stage 1 in 2015, depending on where you started and when you started your meaningful use. However, most users will be in stage 2 this year. There's a lot of ground to cover. There are some new objectives this year. Some have stayed the same. Some have higher percentages. Some have more than one measure. Some objectives that used to be menu are now core, and then in general there are just some new ones. So I'm going to focus primarily on the new ones and spend a lot of time on those and just kind of quickly review the ones that haven't changed too much. I'm going to just talk about the objectives. I'm not really going to get into what you need to do in the software. There is a very detailed step-by-step instruction guide on how to meet each one of these objectives. McKesson has published a guide called the EHR Meaningful Use Stage 2 Guide, Configuration and End User Training. At the end of the webinar, I'm going to put a link to this resource. Everything will be published on the AVS Medical blog, and I'll show you how to get there, and you'll be able to have all of that information. So, where are you today? First, before we get into 2015, let's just wrap up 2014. So your data collection period for 2014 ended on December 31st, but you have until the end of February to register and attest your 2014 meaningful use data. Okay. Where you are in 2015 depends on which year you started your meaningful use journey. Every provider spends 2 years in stage 1. So, as an example, if last year, 2014, was your first year of attestation, then in 2015 you'll still be in stage 1. The best way to kind of figure out where you are is to use a really nice tool that CMS has developed called My EHR Participation Timeline. And there you see a link to it down there. Let me go ahead and actually click on this link. Let's go to the website and take a look at it. Okay, so we come into the My EHR Participation guideline. And the way we use this is we come down here and we click the Start button. And my presentation today is based on the Medicare program, not Medicaid, so I'm going to go ahead and click Medicare. And when I do, it asks me to put in the first year that I did my attestation. So in this little example, I'm going to pretend that it was 2013, 2 years ago. So when I choose that 2013 was my start year, I'll hit Submit. And it shows me that in 2013, I had to demonstrate 90 days of meaningful use, and I would get that much reimbursement. And I can click on each year now and see where I was still in stage 1 last year. And 2015, here's really what we're focusing on. This is where I am this year. I'm going to demonstrate a full year, 12 months, of stage 2 in meaningful use, and then this is the amount of payment that's available to me. So that's how you use the My EHR Participation Timeline. As I mentioned, it's a really great little tool that will tell you exactly where you are. Okay. So let's take a quick look at the differences between stage 1 and stage 2. In stage 1, you had to do a total of 13 core objectives and then choose 5 out of a possible 10 menu objectives to report on for a total of 18 objectives for the year. In stage 2, you have to do a total of 17 core objectives and then choose 3 additional menu objectives from a possible 6. And as you'll see when we get into the menu objectives, it's actually 3 out of a possible 5 menu objectives, and I'll explain more. And then, of course, you will still need to do the CQM or clinical quality measure reports, but I'll talk about those in a separate webinar. So most of you have just finished up your 2014 attestation, and I'm sure you're looking forward to a short break. However, as I mentioned a few minutes ago, meaningful use in 2015 requires the entire 12-month attestation period, and it has already begun on the 1st of January. So as we talk today on the 16th of January, you are actually in stage 2 already for 2015. One of the other things you need to be aware of is that you will need to be on the 2014 certified version of your EMR in order to meet either stage 1 or stage 2 this year. You have to be on the 2014 certified version. And below there, depending on which EMR you're using, you will see the version number next to it. And you can open up your software and click on Help and About, and that will tell you which version you're on. But most everybody is on that version right now. Excuse me. Okay. Before we get into the actual objectives, let's talk for a minute about the clinical encounter. Everything begins with the clinical encounters. And if you've been doing meaningful use for a while, you know that there are multiple ways in which a clinical encounter gets created. However, most practices create the clinical encounter from the schedule. When they check the patient in, they change the status of the appointment, and that status change from pending to whatever it is, and it depends on which software you're using, but you should know which one it is by now. When that status change is made, that's what triggers the creation of the clinical encounter. There are other things, though, that you can do in the software to create a clinical encounter, and you have to be careful of that, because it's very easy, if you're not creating them from the schedule, to create a duplicate clinical encounter. Creating duplicate clinical encounters is bad because that drives up your denominator with no corresponding data in the numerator, and so it makes your numbers look low. So the best practice that we recommend is to create the clinical encounters from the schedule by changing the patient's appointment status. All right, so let's jump into the actual objectives. Objective number 1 is computerized physician order entry, or CPOE. There are some significant changes to this objective. In the past, there was one measure that satisfied CPOE, and that was by writing an electronic prescription, which was in fact a medication order. But to meet CPOE this year, there are actually 3 measures that you must satisfy. One for medications, which is basically the same as it was last year, except the percentage is now 60%. But there are 2 new ones. One is radiology orders, and one is laboratory orders. And there's a metric for each one of those, so 30% of each. So in addition to entering medications, you will now need to write orders for labs as well as radiology orders. Now there are exclusions for each one of these. If you write less than 100 of any one of those 3, so less than 100 medication orders, less than 100 lab orders, less than 100 radiology orders, you can take an exclusion for that particular measure in the objective. But other than that, you do need to be ordering labs and radiology orders through the order entry module in the software. Core Objective 2 is e-prescribing and the use of formulary data. The objective here is that more than 50% of all permissible prescriptions written by the provider are transmitted electronically and are also queried for drug formulary interactions. So 2 differences here. The percentage is higher. It used to be 40%. And now they've also tied formulary checking into the actual prescription. Last year and prior years, formulary checking was one of the menu objectives, but now they've added it to this core objective. Core objective number 3 is patient demographics. Pretty much everything is the same as in the past. However, the percentage has gone up from 50 to 80%. And let me call something out here. You see I've got it in red. All of the measures this year have the same verbiage. They all say more than in this case 80% or more than X percent. What that means is you can't report 80%. You've got to report at least 81% in order to get credit for this and any other measure. So it's more than, which is a subtle but big change from prior years. Excuse me. Okay, core objective number 4 are your vital signs. Pretty much the same here as in the past, with the exception that the percentage has now also increased to more than 80%. And you need to record height and weight, as well as blood pressure for patients ages 3 years old and older, as well as calculate and display the BMI. Now the software automatically calculates the BMI. And one important note here is that patients can self-report their height. You don't actually have to measure their height. But there are some exclusions here to this one. And the exclusions are that if you don't believe that all 3 vital signs of height, weight, and blood pressure are relevant to the scope of your practice, you can take an exclusion. There are also exclusions for if you feel that blood pressure is not relevant to the scope of your practice. You can take an exclusion. And if you, on the other hand, if you feel that blood pressure is relative but height and weight are not, you can take an exclusion for that. So several different ways to take an exclusion for all or part of this objective. Core objective number 5 is documenting the smoking status. Similar to the past, you must record smoking status for patients that are 13 years old and older. And then once again, we see an increase here to more than 80%. One quick note is that the vital signs must be documented in the smoking status must be documented in the vital signs section of the chart, not the social history or not in the note. It's got to be documented in the vital signs section of the chart. Core objective number 6 is clinical decision support. So this one is similar to what it was in the past, although there's a few additions to it. So to satisfy this one, there are actually 2 measures. And the first measure is that you must implement one clinical decision support rule that's relevant to your specialty or that improves the performance in one high priority health condition area. The objective here has been expanded from previous years. So to meet this first measure, you need to implement 5 clinical decision support interventions that are related to 4 or more clinical quality measures. Okay, so I'll say that again. You have to implement 5 clinical decision support interventions that are related to 4 or more clinical quality measures. And the way you do this is through the health maintenance module, tying in the CQMs to the health maintenance modules. There is no percentage on this one. It's simply yes or no. The second measure that's required here is that you have drug-drug and drug allergy interaction checking turned on and enabled throughout the entire EHR reporting period. So you've already got that in your software and that should be turned on. I will mention, this is a good time to mention again, that in that McKesson Stage 2 configuration and end user training guide, there are step-by-step instructions on how to customize your EHR to do that. Okay, core objective number 7 is to provide patients electronic access and give them the ability to view, download, or transmit their health information within 4 business days of that information being available to the provider. So this one is WebView, the patient portal. It's going to require that you have that WebView software installed and configured. Now there are 2 measures that are required to satisfy this objective. The first one is that for 50% of your unique patients or their representatives, that you give them electronic access to their health information. So if you met Meaningful Use in 2014, you probably already know how to do that. You just go into their chart, give them access to WebView, let them know about the access to the WebView, give them their username and their password, and show them how to get in. This is basically the same percentage that was required last year. But now there's a second measure to this one. And let's actually go ahead and go over to the next slide. The second measure to meet core objective number 7 is that in addition to giving them access, that 5% of all unique patients or their representatives actually go to the web portal, the WebView software, and use it. They either view, they download, or they transmit their health information to a third party. And here's a list of things that should be made accessible to the patients at the portal. I won't read through that list. I'll just sort of let you take a look through there. And again, you'll have all these slides at the end so you can see it. But these are the things that they should have access to at the portal. And so this measure, again, is that there's two measures to meet this objective. The first is 50% of all your unique patients have been given access to it. They don't have to use it. But the second measure is that 5% of your unique patients actually do use the web portal. And as we go forward here, I'll talk about a couple of strategies to drive compliance or drive usage of the portal from your patients. And the first way we would do that is the clinical summary. So core objective 8 is our friend, the clinical summary. And you must provide a clinical summary for patients for each office visit. And the first thing I want to point out here is that this is not for unique patients or unique visits. A clinical summary must be given for every visit. So if in the past you've looked at your performance metrics reports and you've noticed that your denominators for almost all the objectives are usually about the same, there's one or two where it's drastically higher, and this is one of them, because it's not just for unique visits, it's for all visits. You've got to give them a clinical summary of their visit. The measure here is 50%, or more than 50%, the same as it was. But the other big difference here, and this is big, is that in the past you had up to 3 business days to get it to them. Now you've got to get it to the patient within 1 business day of them being seen or of the information being available to you. So that really means you need to give it to them on the same day. Our best practice recommendation here is that you do it the day the patient is there in the office. You do it before they leave, and it kind of makes sense to do it as part of the checkout process. To give them a clinical summary, there's several ways to do it. You can print one out and hand it to them. If they don't want one, you can also check off that the patient refused a clinical summary, and that also gives you meaningful use credit. But probably the easiest way is to send the clinical summary to the web view, to the patient portal. And when you go to print it, there's a little checkbox that says send to portal. And when you click that, it sends the it sends the clinical summary to the web view portal. And then the patient gets an email that says the doctor has just provided information for you. Click here to go to it. So that does 2 things. Number 1, it gives you meaningful use credit for giving them a clinical summary. But as importantly, it encourages the patient to go to the portal and check and take a look at it. And that drives your patient portal usage that we talked about in that last slide. So that is the clinical summary. Okay, core objective number 9 is another yes-no attestation. This is the security risk analysis. You need to conduct or review a security risk analysis and implement security measures as necessary to bridge any identified security gaps as part of your process. You probably did this in the past, but you need to do one every year. There is no percentage here. It's simply a yes or no. CMS has published a very nice security and risk analysis tool, and you see a link to it right there. You don't have to use that one. You can use others. There's a lot of third-party stuff out there that will help you do this, and there's actually companies out there that you can pay to do it for you. I have talked to a lot of practices who have their IT team do this because a lot of the questions relate to IT. So take a look at that, download that link, and sometime during the year you need to go ahead and conduct that security risk analysis. And I would encourage you to do it early in the year and put those remedial actions in place to address any shortfalls in the practice security. Okay, core objective number 10 is to incorporate structured lab results. Okay, this used to be a menu objective, now it is a core objective. And to meet this objective, it requires that you are ordering lab tests via the order entry module and then recording the results for those ordered lab tests as structured lab data. This measure can be met whether you're entering lab results manually or whether you're getting them via a lab interface. Although this one can be done manually, it's much easier to meet this one if you do have both a lab orders interface and a lab results interface. I believe that most people already have a lab results interface. If you don't, or you don't have an orders interface, please contact your lab rep and tell them that you would like an orders interface and a results interface, and your lab reps know what to do. They contact us, and then we'll start the process for getting you those lab interfaces. Okay. All right, that is structured lab data. Core objective number 11, this is another one that used to be a menu objective, is now a core. And this is that you have the ability to generate a patient list by problem. This one can be satisfied by one of two ways. You can run the patient inquiry report to generate at least one report of patients that all have a specific condition, or you can use the patient registry function. They'll both give you credit for this particular objective. It is yes, no. There is no metric on this one. Okay, core objective number 12 is the ability to generate patient reminders. By sending reminders to patients based on their preferences for either preventative care or follow-up care. So they're not really talking about appointment reminders here. They're talking about care reminders. As an example, it's time for your annual exam or your semi-annual blood test or whatever those sorts of care reminders are that you normally do. You need to you need to contact the patient and let them know. There is a metric here. It's 10% of all unique patients. You can satisfy this objective by sending the patient a secure message through the WebView patient portal. Again, that's a nice way to do it because it drives patients to use your portal. You can also meet this objective by sending the patient a printed letter or by a phone call if you use the batch communications feature, and you can document that you've given them a phone call to remind them of their follow-up care. Okay, core objective number 13 is to provide patient-specific education. Once again, menu objective last year, core objective this year. This one's very straightforward. It's the same, more than 10% here, but either using the patient education .code in a note or by using the patient education module, you can document that you've given them patient education resources. Core objective 14 is medication reconciliation. Used to be a menu objective, now it's a core. The percentage is the same, it's 50%. So 50% of all the patients that you receive from another care setting or another provider, or on all visits where you believe a medication reconciliation is relevant, you would do a medication reconciliation. If the patient is bringing you a CCDA file, you can import that CCDA file, whether they have it physically in their possession or whether it's been messaged to you via secure message connection. You can import that CCDA file and that will do your medication reconciliation. Or you can do it the more, I'll say, typical way that you've probably done them in the past, which is to compare the paper list or compare what the patient tells you with what's in their chart, and then document that you've done a medication reconciliation by using the MedRec button in the medication section of their chart. I think most of you are probably familiar with that one. Okay, core objective 15 is a summary of care record. This one's a little bit, I'm going to go into a little bit of detail here because this one can be a little confusing. So it used to be a menu objective, now it's core, meaning mandatory. And the big change here, or one of the big changes here, is that there are three separate things or measures that you have to do to meet this objective. Okay? The first measure, or the first thing you need to do to meet this is you need to generate a summary of care record on more than 50% of all the patients that you transition to another care setting or another provider. So not on 50% of all your patients that you see, just 50% of those that you are transitioning or referring out of your practice or sending to another care setting. There are a list of requirements that need to be on that summary of care, and if there's a hyperlink there that will take you to the CMS page that tells you what those things are, but know that they are the standard default things in the summary of care record. Okay? That's the first thing. That's the first measure. Let me change the slide and go to the second one. Measure 2 for this objective is that for more than 10% of those patients that you are transitioning, that you provide that summary of care with a direct message to the recipient. And the operative words there are direct message. So direct messaging is something new for many of you. It can best be thought of as a secure email between you and another provider. The direct messaging is something that is separate of the WebView portal, and it requires its own direct account. Its own direct email account is required, but it's a secure and it meets the HIPAA guidelines. Fortunately, McKesson will set you up at no cost for the direct message account. So we've got a form. We'll make it available on our blog. You can download it. And you fill out that form, and then they will set you up with a direct message account. And there's some setup you need to do in the EMR, but it's all in that guide on what you need to do. So the third and final measure to meet core objective 15 is that you conduct one test, one electronic exchange of summary of care information with another provider or a facility, and it has to be a provider outside of your practice, so you can't do this with just another provider in your practice. And they need to use a different EMR, or you can actually send it to CMS. They've set up a test EMR that you can use to send a test file to. There is no performance metric here. This third one is just yes or no. So that all three of those relate to the core objective 15 summary of care record. Okay, core objective 16 is that you have the capability to submit electronic data to state immunization registries. This was also a menu objective in the past, but now this is core. The other difference here is that in the past, you had to submit a test file, at least one test file, and submitting the test file one time was enough to satisfy the objective. This year, you must successfully submit ongoing immunization data to your state registry. So instead of that one-time test, you need to set up a connection to the state registry and send them immunization data routinely throughout the year. Now, if your practice doesn't give immunizations and or your state doesn't have the capability to accept them, you can take an exclusion for this one. Excuse me. This one does require the immunization interface be installed on your server. And unfortunately, right now, that immunization interface does not currently support bidirectional exchange of data, nor does it offer a real-time data extract. So once you get the immunization interface set up, you will need periodically, from time to time, once a week, once a month, I'm not sure what that time interval is, you may need to check with the state, but you'll need to go in and manually run the immunization export. It's not hard to do. It's a couple of clicks of the mouse, and it will pull all your immunizations together, and then each state is a little different on how it's transmitted to them. But we'll check with them and see how that goes, or how that is set up. Okay, that's core objective 16. Core objective 17 is the use of secure messaging in the EMR to communicate with your patients on relevant health matters. So you need to send at least one electronic secure message to more than 5% of your unique patients or their representatives during the attestation period, during the year. Now this one does require the WebView patient portal, so you'll send that secure message, or you'll receive that secure message through your portal. Now what they mean by the patient's representative, a couple examples of that is if you're pediatrics, then you're probably getting those messages from the parent, or if you're dealing with an elderly family member, then a child or a sibling might be sending that message on their behalf. And you identify those people in their record, so you know who that other person is that's sending you the message on behalf of the patient. Okay, that wraps up the core objectives. Quite a few changes there, as you can see. Let's now talk about the menu objectives. And if you remember at the outset, I mentioned that you need to choose 3 menu objectives from the 5 that McKesson has available for you to use. So the first one is submit electronic syndromic surveillance data to public health agencies. The last time I checked here in Maryland, as well as Virginia, Pennsylvania, Delaware, Ohio, Michigan, most, if not all states, do not accept syndromic surveillance data. For whatever reason, they just don't. So this may be, unless things have changed, and I'm not aware that they have, this one may be a moot point, so I won't go spend too much time on this one. I'm just going to move on to the next one. The next one, very straightforward, very easy, is that you are using electronic notes in the patient's record. So pretty much everybody's doing this. This should be a slam dunk for everybody. The measure here is that 30% of the unique patients that you see have at least one electronic progress note that was created, edited, and signed by the eligible provider. I think pretty much everybody is already doing this, so this should be number one, the number one menu objective that you do. So menu objective number 3 is that images and imaging results are accessible through the CERT. And CERT is just an acronym that means Certified Electronic Health Record Technology, or better known as your EMR. There is a metric with this one, and the metric is that 10% of the images and the results of the imaging tests that were ordered by the provider are accessible through the EMR. And the way that these are accessible is through the Zoom scanning module. Now, if you have an interface today to a radiology system, that will not count if they're just radiology reports that are being pulled into the patient's chart. You actually need to link your Zoom scanning software to, use an example, a hospital's PACS system, or so the hospital's imaging system. You do have a way to go in and set up a link to that external system, and then you can click and browse that system, find your patient's image, link it to the patient's chart through Zoom. So you need to do that on 10% of all the images that were ordered by the provider during the 12-month attestation period. Menu objective number 4 is family history as structured data. There is a metric here. It's more than 20% of the patients must have their family history for first-degree relatives recorded as structured data. So this is a new one. You've probably, as everybody has, been documenting family history in the family history section of the chart or in the note. But in the 2014 version, you have the option now to view family history either in the note format, which you probably have been doing forever, or in the new grid format. And in order to record family history structured data, you have to use it and enter it into the grid format of the patient's chart. One caveat on that, though, is that when you go into, and let me just tell you briefly how you get to that. If you want to see that, you would open up your dashboard, not a chart, but go to the dashboard, click on the menu that says Maintenance, and then when you're in the Maintenance section, you'll go down to the drop-down menu. You'll choose Configuration, and when you click on Configuration, you'll click on Special Features. Click on Special Features, and you'll see a list of chart tabs, or excuse me, record tabs. And on record tab number 5, at the bottom is the ability to choose either Note View or Grid View. So you would change it to Grid View and look at your family history that way. Now, one caveat, it's based on the way the software works. Even if you have family history already recorded in your software, when you switch to the Grid View, that family history that was already there does not pull forward. So if you've got a patient there, you've been seeing them and documenting them in the chart in the past, when you open their record up in the Grid View, none of that family history data will be there. You'll need to re-enter that, at least for the first-degree family member. So you may want to set up a staff person and ask them to go through and do that. It's easy to do and should be one of your menu objectives that you might want to look at choosing that one. Okay, going to kind of breeze through the last 2 menu objectives, and that is the use of a cancer registry and the use of a specialized disease registry. In 2014, the ONC, the Office of the National Coordinator, has said that a certified EHR does not have to meet these 2 criteria. So right now, your McKesson EHR does not have the capability to meet these two objectives. So you'll need to choose from your three menu objectives from the four, or excuse me, yes, the four that we've already talked about. Okay, so we cannot use this one. Okay, the last thing I want to mention before I wrap it up and start taking some questions is the performance metrics report. It's the same as it has been in the past, but when you open up the performance metrics report and you're doing it for 2015 stage 2, you're going to want to change it. You want to change your performance objectives to stage 2. You'll notice right below the report from and the report to date that there's a drop down that will allow you to change which stage you're in. Now, if you want, we can go in and change it so that it always defaults to stage 2. Give us a call or go to our support portal and ask us to make that change for you, and we will we'll take care of that for you. Okay, but change that report. Okay, before I get into the questions, let's talk about additional resources and where to go to find copies of all of this information. This year we're going to publish everything on the AVS Medical blog. And I want to encourage everybody to go ahead and sign up today while you're thinking about it. And the way you do that is you go to the avsmedical.com webpage, and on the far right side of that webpage across the top is a button that says blog. As we speak today, there are two blogs. There is one dedicated to ICD-10, which you may or may not want to sign up for that one. But go ahead and just check on the one that's, subscribe to the one that says blog, and that will have all of this information. The benefit of that is if we put information there and you subscribe to it, and you subscribe to it, by the way, by just putting in your email address and hitting the subscribe button. As we post things on the blog, you'll get an email indicating that something new is there. If we change anything up there, as an example, the McKesson resources are updated throughout the year. You'll get an email saying that something has been updated. And as we post information from CMS, you'll also get information that an email saying that that information has been changed. There'll be links to the video presentation that you're seeing now, and there'll also be linked to those McKesson step-by-step guides. So take a moment, go to the blog and sign up. You won't get a bunch of spam or anything along those lines. We've already got your email addresses, obviously, but just go ahead and put them in there. We can't put them in for you. A blog, the kind of theory behind a blog is it is opt-in. It's something that you do. So all of that said, let's go ahead and I will take your questions. I really appreciate you taking the time out of your day today to spend it with us and listen to me talk here for an hour or so. Thanks once again. Please go to our blog and sign up so that you get that information as it is presented.